Hello, everyone. Today we will discuss a very interesting and important topic, which is the link between obstructive sleep apnea and gastroesophageal reflux disease. The agenda for the talk would be we will begin with the introductions to both disorders and look at the complex interplay between the two in terms of the pathophysiological link and how are they linked? Is it bidirectional, causal, or there's none? And what role CPAP has to play with regard to this correlation and what the conclusions we draw from here. So, obstructive sleep apnea, as you know, is characterized by disordered breathing during sleep. It's a temporary upper airway stricturing which occurs during sleep, causes sleep fragmentation, intermittent hypoxia, autonomic fluctuations leading to sympathetic arousals and disturbed sleep. Along with that, people have excessive daytime sleepiness when they complain of OSA. So, epidemiological studies were collected from 11 population. They had the data from populations of US, China, Spain, India, Korea, Japan, and Sweden. And these studies came to the conclusion that about 17% of women and 22% of men suffered from OSA, which is a significant number. So we will just look at this graphical representation of OSA by way of AHI being more than 5 across the world. We can see that the prevalence of OSA in India is 9.6%. And this number will go into millions of people looking at the fact that we are the most populous country in the world. On the other hand, when we look at gastroesophageal reflux disease, it is a functional GI disorder characterized by heartburn and regurgitation. And current epidemiological researchers have shown the prevalence of GERD has been significantly increased over the past 10 years. Pertinent question arises. They are very commonly seen disorders, commonly associated disorders. Patients of OSA are commonly known to have GERD. This is a common knowledge. And is it actually a coincidental finding, or is there a correlation between OSA and GERD? Is it a causal? Is it bidirectional, one leading to the other, or none? So, what pathophysiology actually is at work? This is what we will try to decipher in the coming few slides. A population-based analysis was conducted using national inpatient sample data from more than 7 million patients after they had adjusted for risk factors like age, comorbidity, gender. Then OSA patients were found to have significantly higher incidence of GERD compared to those without OSA. Another study was conducted by Emerson and in 2016, and he found that it is not just that GERD is more common in patients of OSA, it's also that patients of GERD had more often seen to have phenotypes like snoring, which are related to OSA. Both these studies were based on large sample size, and similarly, there was this study which involved 22 million patients. More than that, they just revealed that 12.21% of GERD diagnosed individuals, they were also diagnosed with OSA. And only 4.79% of non-OSA, non-GERD patients had OSA. This is these studies, meta-analysis, with a sample size of over millions of people. So their quality of result, it's a higher quality result and more generalized. Again, there was a study in which patients with erosive esophagitis manifested more abnormal OSA-related sleep indices than those with GERD symptoms, but normal upper GI and microscopy, which indicated that it is not just GERD which is related to OSA, but also the severity of GERD by way of erosive esophagitis or developments of Barrett's esophagus. They are also related to the severity of OSA and how OSA disturbs the sleep-related indices. So another very interesting study, there was a positive Mendelian randomization study, and the data was derived from a very large genomic-based association study on GERD in European population. over 6 million people participated in it. It indicated that there is a positive correlation between genetically predisposed GERD and the probability of experiencing OSA. So, such trials like the positive Mendelian trials, where they rule out a lot of comorbidities, they rule out a lot of confounding factors, and they talk on the basis of genetics. And it has been found that genetically GERD is predisposing a person towards development of OSA, not just OSA, but other sleep phenotypes like insomnia and snoring are also predisposed by GERD. So, besides these researchers, which are giving a very positive feedback in terms of a correlation between OSA and GERD, there are some studies which talk contrary. So there was a study of more than 1,000 patients from Sleep Disorder Center, and GERD was found not correlated with OSA, and the severity of OSA did not affect the prevalence of GERD. So this was one. There are few and far and few between. There are some studies which have found such things like Morse et al. Again suggested that while patients reported sleep quality was positively affected by GERD severity, no correlation he could found between GERD and OSA. Probability of getting these kinds of results where no correlation is found is there. But however, what we feel that this could have been because of that OSA and GERD, they share a lot of common risk factors. They can act as confounding factors in these studies, which can bias the result, and also the fact that all these studies which have shown a negative relationship between the two entities were based on small patient sample size. Now, so till here, we can conclude that yes, there is a correlation between GERD and OSA. But what pathophysiological interplay is at work, that is very important to know. One of the reasons is that OSA might decrease gastric emptying, and it causes transient reflex activation of lower esophageal sphincter smooth muscles, and thus the transmission of pressure to lower esophageal sphincter, thus increasing the probability of reflux. OSA may increase transdiaphragmatic pressure, and also sleep apnea reduces the intrathoracic pressure or increases the negative intrathoracic pressure, again favoring an acid reflux. Again, there are significantly respiratory efforts are involved after the apnea episodes, and they again tend to increase the pressure gradient across the esophageal sphincter, the lower sphincter, and again causing a retrograde movement, thus leading to reflux. Another pathophysiology which could be at play is inflammation and irritation caused by microaspiration of gastric contents. They cause mucosal swelling and spasm of the upper airway and the area surrounding the lower esophageal sphincter by way of the vocal cords, the vocal folds, the larynx, the lower pharynx, and all this mucosa, when it thickens, the diameter of the airway narrows, and this predisposes somebody who has GERD to develop OSA. Bronchial constriction, it's also stimulated by vagus nerve, which is stimulated in patients with GERD and ultimately can result in snoring and even sleep apnea when it is severe. Acid reflux may stimulate the vagus nerve, inhibiting the medullary respiratory center and preventing proper contraction of respiratory muscle. So the proper ventilation, perfusion, and the respiration's mechanism is hampered because of the disturbance of the vagus nerve as a result of GERD. Another mechanism that has been postulated is that oxygen deficiency and carbon dioxide retention caused by apnea and hypoventilation. It lowers the intracellular adenosine triphosphate, decreases the influx of calcium into muscles, increases tissue acidity, and decelerates the contraction and peristalsis of GI tract. When the contraction is decreased, there's a relaxation of the lower sphincter and increase in the chances of retrograde movement of the acid, causing reflux esophagitis. Again, studies have shown that improvement occurs in the symptom of GERD in OSA patients who are using CPAP regularly, and a strong correlation has been found between CPAP pressure and improvement of GERD symptom. Another study aimed to investigate the effect of CPAP pressure on swallow-induced relaxation of the lower esophageal sphincter found that CPAP significantly increased end expiratory esophageal pressure, lower esophageal pressure, and gastric pressure during quiet breathing, thus preventing the reflux. Again, meta-analysis have better quality results because of the large sample size involved. So there was a meta-analysis by UZH and Pan Ekrel, and it showed that CPAP treatment significantly reduces the incidence of reflux events in patients with OSA, and the improvement in reflux is more obvious with the extension of treatment time. So to conclude, all said and all the contrary evidences, when we have taken a look at them, what we have found that there is a correlation which is bidirectional. So it becomes better if patients with OSA are investigated for the presence of GERD and GERD related complications and they are managed on time. More studies with large sample size and objective monitoring are required for analysis of GERD and OSA interplay because the studies we have till date, not all of them are based on objective parameters like polysomnography and objective parameters for GERD. So, if we get some objectively defined studies, it will be a better quality data for us and it will help us better define the direction in which this correlation will progress. Then, again, the rapid development and widespread use of portable wearable devices, it may provide little bit objectified and accurate sleep data for large scale studies. So those devices who are validated and they are feasible, such devices can be widespread used so that we can get a lot of data and we can proceed to further objectification of this correlation, and thus more research will be generated and more clinical outcomes will be there and better clinical outcomes can be got for the patients. So with that, thank you so much.